Hello everyone, welcome to my channel Samvedna Psyche. Today we are exploring a crucial skill for psychology students, that is writing case study report. Whether you are starting your journey in psychology or seeking to enhance your academic abilities, this video will help you in developing your skills in case report writing. Now without further ado, let's get started. Case study report includes case history taking or intake information, mental status examination MSc, interview session, tools and tests done, diagnostic formulation and diagnostic impression. I'll be sharing two cases. The first is based on the format commonly used and the second one precisely as per IGNOU guidelines. In case report, first of all the case number is written followed by the title of the case, date and the registration number. So, socio-demographic data of the patient is collected, which includes name, age, sex, marital status, occupation, education, religion, family, type, locality, socio-economic status, and language. The information about informant is recorded. In this case, patient's mother is the informant. Reliability and adequacy of the information is seen, how reliable or adequate it is for the purpose of diagnosis. Chief complaints or major problems according to the patients are noted down. In this case, the patient feels neglected due to father's limited time and attention, feels unfairly blamed for declining academic performance, believes teachers' partiality affects performance, lack of interest in studies, prefers spending time outside with friends and doesn't feel like going home, tends to withdraw at home and communicate less with the father. Sister's departure for hostel has left a significant void in his life. Major concerns according to the informant, that is mother. She is concerned about changes in his behavior, including withdrawal at home, decreased communication with the father, and sleeping less. Notices the patient's preference for spending time with friends outside and reluctance to return home. Expresses frustration over perceived unfair blame placed on the patient for academic struggles. Seeks support in addressing the patient's feeling of neglect due to father's limited time and attention. Observes that his eyes appear dull and red and his emotional state worsened due to sister's departure for hostel, adding to family dynamic challenges. Total duration, precipitating factors. These are the factors which are responsible for the present or current state of the patient. Mode of onset can be gradual or sudden. History of present illness is based on the information gathered from the patient as well as the informant. Negative history, if any, is recorded. In this case, there was no negative history as no indication of underlying physical issues or use of substances affecting mental health. The patient denies experiencing extreme states of mood such as euphoria or depression. No reported history of recurring intrusive thoughts or repetitive behaviors. Past illness history, not at all. Treatment history, none. Medical history, no significant history of chronic illness or ongoing medical conditions. Family history, no reported psychiatric illness or significant medical conditions in the immediate family. Patient and family setup, here relationship of the patient with family or within the family setup is seen. So this patient's relationship with father is strained. Father has limited time for the family. A notable lack of communication between the patient and his father for the past year. On the other hand, he receives caring and supporting behavior from his mother. Personal history includes birth history. Here we mention whether this particular individual was a full-term delivery or premature delivery, whether it was normal or cesarean or any other complications were there, typical crying response at the time of birth was there or not, developmental milestones were age appropriate or not, if there were any childhood disorders or diseases, and what is the environment at home. Educational history. This patient is studying in class 12, has demonstrated excellent academic performance in the past. Despite a recent dip in academic performance, he continues to maintain healthy peer relations and there have been no disciplinary concerns reported at school. Occupational history not applicable. Sexual history, he demonstrates a normal curiosity about sexual development and engages in exploring information about sexuality online. There are no signs of aberrant sexual behavior. Marital history not applicable. Habits and addiction, no concerns have been reported. Pre-morbid personality includes attitude towards work and responsibility. He displays a generally responsible and diligent approach to his work and responsibilities and a commitment to fulfilling his obligations effectively. Interpersonal relationship generally good. However, there is a notable strain in relationship with his father, which has led to withdrawal and communication difficulties. Standards in moral, religious, social, and health matters. He holds a high standard in moral, religious, social, and health related matters. This reflects in his commitment to maintaining balanced and ethical lifestyle. Energy and initiative are in harmony with approachability and adaptability, reflecting in a balanced disposition. Fantasy life, firmly grounded in reality, not living in a fantasy world. Hobbies, has a strong passion for football, basketball, and enjoys socializing with friends. After this comes the mental status examination. In this, we assess the present state of the client and presence and extent of some mental impairment, if any. General awareness and behavior. This is observed and noted down. The patient, a tall and well built adult adolescent, walked in with a confident and coordinated gait and displayed a balanced posture. He was neatly and appropriately dressed, demonstrating good grooming habits. He appeared comfortable and at ease during the assessment, maintaining a cooperative attitude and establishing rapport was relatively straightforward. Psychomotor behavior. The patient exhibited deliberate and well coordinated movements throughout the assessment. No psychomotor abnormalities were visible. Voice and speech. The patient's voice was audible within normal fluctuation in tone. The rate and volume of speech were within the typical range, displaying no notable variation. Affect refers to observable expressions of emotions. So, in this case, the affect was predominantly flat with limited facial expressions and subdued emotional responses, indicating potential emotional blunting. Mood refers to verbal expressions or the tone in which the patient answers. So, mood was melancholic and relatively stable in this case. Thought includes stream of thoughts, which refers to the continuity and coherence of a person's thought process. Possession of thought, this evaluates the patient's ability to recognize and maintain control over their own thoughts. And form of thoughts refers to the structure and organization of patient's thoughts, assessing their logical coherence. Insight, it is assessed by evaluating the patient's awareness and understanding of their own thoughts, behaviors, and consequences of their action. Attention and concentration is observed, and in this case, he exhibited sustained attention and adequate concentration. Mild irritability was noted towards the end. Orientation is seen in reference to time, location, and self identity, etc. So, he displayed clear awareness of current time, location, and his own identity. Memory, all the three types, immediate, recent, and remote memory, are checked by asking questions related to these three. Abstract thinking, it is the thinking which goes beyond the concept of literal interpretations. So typically this is tested by uh, asking the patient to tell the meaning of some proverbs of by asking them to solve some problem. Then intelligence, it is evaluated through various cognitive tasks and tests to assess problem solving abilities or reasoning skills and also overall intellectual functioning. Judgment is observed through patient's ability to make appropriate decisions and choices in various situations like in personal, social, or tests. Then diagnostic formulation. This refers to significant features of client's history. So we include all the significant features of client's history in this. XYZ, an 18-year-old unmarried male, hails from a nuclear Hindu family, is in an urban affluent setting, currently in grade 12 and unemployed. He was accompanied by his mother and presented with concerns about feeling neglected due to his father's limited attention and unfairly blamed for his academic decline, which he attributes to perceiving teachers' partiality. A lack of interest in studies, tends to withdraw at home and communicating less with father. During mental assessment, uh, the patient appeared well groomed and attentive to his surroundings, consistently maintained eye contact, demonstrating active engagement. His clothing was appropriate and his hair and nails were neatly maintained. Establishing rapport with the patient was a straightforward or easy process. He displayed predominantly melancholic demeanor and mild hints of irritability. His capacity for abstract thinking and judgment was within expected parameters, indicating sound cognitive function. Additionally, there was evidence of intact insight. Diagnostic impression, this refers to provisional diagnosis, what we have diagnosed. So in this case, it was seen that there is some underlying emotional distress which is potentially stemming from the unresolved family conflicts, particularly strained relationship with his father. Teacher's partiality and academic decline also contribute to his current emotional state. So with this, we have completed the first case. In this case, I have not included any test or interview because otherwise the video will become too long. I'll be discussing the interview as well as one tool in the second case. Let's move on to case number 2, which is precisely based on the guidelines provided by IGNOU. So first of all, the case number, title of the case, date and registration number. The intake information regarding the patient is taken, which includes name, age, gender, educational qualification, occupation, income, marital status, whether client stays with parents or not, number of siblings, position of the client in the family, anyone in the family having conflicts, anyone in the family is suffering or has suffered from any physical or disorders or not. Presenting problems are the chief complaints as told by the patient. So the patient is experiencing persistent feelings of inadequacy and low self-esteem, which he attributes to growing up in a competitive environment with high expectations. He expresses difficulty in meeting the perceived standards set by his parents and brother, leading to a sense of not being good enough. This has resulted in negative self-talk, affecting his confidence and self-perception. He reports avoiding challenges due to fear of falling short of expectations. The subject has also observed a recent decline in energy levels, leading to fatigue and difficulties with sleep, including trouble falling asleep and experiencing restless nights. He struggles with task efficiency and experiences discomfort in social situations, particularly in large gatherings or new environments. These challenges are impacting his work, relationships, and overall well being, prompting him to seek assistance in developing effective coping strategies. Date of onset of the problem, it has been for several years. Precipitating factor, he reported that while these feelings of inadequacy had been present for some time, they notably intensified over the past couple of years. He identified his younger sister's graduation ceremony as a turning point, which left him grappling with a profound sense of falling short. Duration of the problem, it increased gradually in 2 years. Prior counseling not taken. Intensity of the problem according to the client consistently grapples with participating in daily activities, describing his emotional state as overwhelming, which in turn affects both work and personal relations. There are moments of noticeable reluctance towards engaging in routine activities, accompanied by an expressed desire to withdraw from certain responsibilities. According to the informant, here informant was the elder brother of the client. The client's elder brother observes a notable shift in client's demeanor and functioning. He notes a decline in confidence and pervasive sense of self-doubt. This has led to evident difficulties in various aspects of client's life, including work and relationships. The brother acknowledges instances where the client has found it necessary to take leave from work, sometimes struggling to carry out routine tasks and occasionally expressing a lack of motivation to engage in any activities. Additional concerns, according to the brother or the informant, he expressed several additional concerns regarding the client's well-being. He observed that the client tends to measure his own accomplishments against those of others, which contributes to his feeling of inadequacy. Additionally, he observed a decrease in client's participation in activities he once enjoyed, indicating a notable loss of interest. The client lack of vitality and enthusiasm, along with signs of irritability and mood swings, are worrisome for the brother. He also mentioned that the client frequently declines invitations to events or gatherings, further isolating himself. The brother emphasized that the client often expresses feelings of tiredness and weariness. Relationship of the patient with family members, if unmarried, with mother, father, sister, and brother. Any other relative staying with patient or not? The relationship with friends, the client has a small but close-knit group of friends. He is known for his loyalty and is often sought after for advice or support. With neighbors, the client maintains a polite and friendly relationship with his neighbors. While he doesn't engage extensively, he is courteous and approachable. With school and classmates, in school, the client was regarded by his classmates. He interacted amicably and was known for his cooperative nature. Educational history. The client's academic performance has remained consistently satisfactory, culminating in successful completion of BTech degree. Throughout his educational journey, the client consistently met the expectations set by both parents and teachers. No observable decline or deterioration in academic performance has been noted. There have been no reported complaints from school authorities eh, regarding the client's academic achievements. Work history. The client is a software development and engineering professional. He typically maintains regularity in his work, although there are occasions where he may need to take leave. He had not voiced any specific complaints about the workplace. Generally, the client has been performing successfully, consistently meeting the expectations of his superiors. In terms of relationship within the workplace, the client fosters a professional and respectful rapport with his boss, being valued for his contribution and technical skills. Among colleagues, he is known for his cordial and cooperative demeanor, often recognized as a team player. Additionally, with subordinates, the client demonstrates effective leadership qualities and is highly regarded for providing guidance and support. Next comes the mental status examination. Here, appearance. 28-year-old male, neatly well groomed and appropriately dressed with subtle signs of nervousness and apprehension. Movement and behavior. Gait is cautious, posture hesitant and retracted. Coordination, control, eye contact, intermittent and cautious. Facial expression, curious, apprehensive and self-restraint. Affect, subtle signs of apprehension and emotional discomfort. Mood, anxious and melancholic. Speech, volume of speech, rate of speed or speech is seen, the length of answers, whether they are too long or too short or appropriate according to the question. The appropriateness of the answer is seen, whether they are contextually appropriate or not. That is, whether they are related to the question asked or related to the topic. Clarity of the answers and similar characteristics are seen. Thought content. Thought content is assessed where we see whether the whatever the patient is saying we see that for the indication of hallucination, delusions, obsessions, or any dissociative experiences. So in this case, the patient, that is Mr. RK, his thought content is free of hallucination, delusion, or obsession, no signs of dissociative experiences. His thought process are clear, organized, and devoid of intrusive or irrational ideation. Thought process. In thought process, we see that whether there is a logical connection between the thoughts and their relevance to the main topic and the conversation, irrelevant details, repeated words and phrases, and interrupted thinking or blocked thinking can be noticed, and it is seen whether the connection between the thought process is logical or illogical, and these all represent signs of some disorder. So Mr. RK's thought process was predominantly linear and goal-directed with coherent association between ideas. He maintained a clear narrative structure, although occasionally tangentiality and circumstantiality were observed. These deviations did not significantly disrupt communication and may warrant continued observation. Cognition. Cognition refers to the act of knowing. So this is in terms of orientation, and it can also be in terms of intellectual level, memory, attention, problem solving ability, time, place, self orientation, etc. So Mr. RK exhibited overall intact cognitive abilities suggesting preserved cognitive functioning. He demonstrated adequate orientation to time, place and personal identity. Memory recall was satisfactory. His accurate retrieval of recent remote memory or information was there. Mr. RK displayed proficiency in arithmetic tasks and abstract thinking, indicating preserved cognitive flexibility and problem solving abilities. Additionally, his ability to understand and perform tasks as well as distinguish between right and left was intact. Overall, the assessment suggests that he maintains satisfactory cognitive functioning across a range of cognitive domains. Judgment. He exhibited sound judgment, providing reasoned and practical responses to hypothetical situations posed during the evaluation. Insight. He demonstrated a fair level of insight, acknowledging the nature and severity of his concerns as well as the impact on his well-being. After mental status examination, now let's move on to interview session. It's not feasible to cover the complete interview session in this video. Instead, I'll highlight key points to focus on during the interview, and while documenting it. While conducting the interview, ensure that the interview session does not exceed a duration of 60 minutes. Begin with a warm greeting, introduce yourself and establish rapport, build a comfortable environment, ensure and encourage openness. Assure the client that any information shared will be held in strict confidence with privacy maintained throughout the session. Ask open-ended questions. Start like with inquiries like how can I assist you today or what brings you here to initiate discussion. Do active listening, pay full attention, maintain eye contact and show genuine interest. Note down the non-verbal cues, observe body language, facial expressions, tone, emotions, etc. Show empathy and respect, demonstrate understanding and sensitivity towards patients' experiences. Avoid leading questions, keep questions neutral to prevent influencing responses. Reassure patient about privacy and confidentiality of their responses. Follow ethical guidelines, respect boundaries, and avoid any form of bias, and do not contradict whatever the client is saying. Towards the end of the interview, summarize and clarify everything, provide a brief overview of the key points discussed, and seek confirmation from the patient. And before ending the interview, thank the patient for sharing their experiences, clarify any doubts if they have, and confirm your next steps, that is, what you are going to do in the next sessions. While the patient is leaving, carefully observe their mannerism, emotional state, or any other notable behaviors, noting down these observations for documentation and further consideration. While writing the interview, take care that it is written as verbatim in a narrative style. Mention the client name, interview number, session number, date, and time of the interview. Purpose of the interview, in this case, the purpose is to understand the current emotional and psychological state of the client. Start of the session, as Mr. RK and his brother entered the room, I greeted them warmly, gesturing to seats opposite mine. They acknowledged the greeting with polite smiles, taking the offered seats. I introduced myself, making sure to address Mr. RK directly. I offered both Mr. RK and his brother a glass of water. As they both took a moment to drink, I observed Mr. RK closely. His appearance was neat and well groomed, indicating a level of self care. However, there was a subtle tenseness in his posture, suggesting an underlying emotional discomfort. His eyes displayed a blend of curiosity and mild reservation. After this initial interaction, I took a moment to engage in small talk. I asked about their journey to the clinic and if they had encountered any traffic. Sensing a more relaxed atmosphere, I suggested that it might be beneficial for Mr. RK and me to converse alone initially. Giving him a space to speak openly, his brother readily agreed and graciously exited. To ensure his comfort, I made it clear that this was a safe and confidential space. I assured him that any information he shared would remain strictly confidential and only details he explicitly agreed to share with family members would be conveyed. As the silence lingered, I gently prompted him and inquired, how I may be of help to you, Mr. RK? So, this way, we ask the first question and then the interview carries on. I'm not going to share the whole process of the interview, but I share how to end it. So, towards the end, as a session concluded, I invited Mr. RK's brother inside to share the insight gained today. I commended Mr. RK for his openness and courage, recognizing it as a significant step towards understanding and healing. I encouraged Mr. RK to engage in self reflection and jot down any emerging thoughts or concerns. We discussed scheduling another meeting, incorporating assessments for a more comprehensive understanding. Mr. RK confirmed his agreement with the plan. Before we wrapped up, I mentioned that I am planning a session with his parents and his brother to provide valuable insights for a more holistic support system. Wishing Mr. RK well, I reminded him to take good care of himself until our next meeting. Then, whatever observations you have noted down, you have to mention while the patient is leaving. These observations you have to make and write down. And lastly, the plan of action. In our next session, I aim to build up the insights gained today. Moreover, considering Mr. RK's reference to familial expectations, I plan to discuss the possibility of involving them in a therapeutic process if he feels comfortable with this approach. Additionally, I intend to conduct further assessments, including the administration of tools or tests to evaluate Mr. RK's self esteem for more comprehensive assessment. With this, we complete the interview session. For this particular case and the patient, self-esteem test was conducted. That was Rosenberg self-esteem scale. So in this scale is a 10 item Likert scale. You can see the 10 statements are there, which are having four options. Each one is having four options starting from strongly agree to strongly disagree. And the patient has to choose one of these according to their choice. Notice that some of the statements or points are marked with asterisk. In scoring, we'll see what is the use of these asterisks. So scoring is done. If the client marked strongly agree, it is 3. For agree, it is 2. Disagree, 1. And strongly disagree, 0. But the items with an asterisk are marked in reversed order. That is strongly agree, 0. Agree, 1. Disagree, 2. And strongly disagree, 3. And once it is done, scoring is done, then the sum of the all 10 scores is taken, and it is compared with the standard score for the self-esteem. Next, we write the report about this test. So in the report, first, the aim of the test. So the aim of the test here is to assess the level of self-esteem of an individual. Materials required: Rosenberg self-esteem questionnaire, pen or pencil. Then we give a brief introduction about this test. Then instructions. These instructions are for the patient or the client. These questionnaires consist of 10 statements that reflect how you generally feel about yourself. For each statement, carefully consider your feelings and choose the response that best represents your own perception. There are no right or wrong answers. If you strongly agree, circle SA. If you agree with the statement, circle A. If you disagree, circle D. And if you strongly disagree, circle SD. Use a pen or pencil to mark your chosen response for each statement, and be honest and respond based on your genuine feeling, as this will help to ensure accurate results. Method of scoring we have already discussed. Now we will discuss how to interpret the scores. If the scores are less than 15, it indicates very low self-esteem. Between 16 and 20, low self-esteem. Between 21 and 25, moderate. And above 25, that is between 26 and 30, high self-esteem. Result: the total of the 10 scores for this patient was 14, and 14 is considered as a low self-esteem. The total score of 14 on the Rosenberg self-esteem scale indicates that the individual may have a relatively low level of self-esteem. Then we interpret and discuss this result. The client's total score of 14 on Rosenberg self-esteem scale indicates a relatively lower level of self-esteem. This score suggests that the client may struggle with feelings of self-worth and confidence in their abilities, as echoed in the client's reported experiences of self-worth and self-doubt, avoidance of challenges, discomfort in social situations. Understanding the client's self-esteem level in the context of this background and experiences provide valuable insight into his emotional well-being. Growing up in a competitive environment with high expectations, the client often compared himself to his parents and brother, which contributed to his current perception of not meeting expected standards. These deeply ingrained beliefs may be influencing his self-esteem. Then conclusion: the assessment utilizing Rosenberg self-esteem scale indicates that Mr. RK exhibits a relatively low level of self-esteem, as evidenced by the opt-in score of 14. This places him below the established threshold. It is important to acknowledge that self-esteem is a multifaceted aspect of the individual's psychological well-being, influenced by a myriad of internal and external factors. Recognizing and addressing a low self esteem is pivotal in promoting positive mental health and overall life satisfaction. By implementing targeted interventions and fostering a supportive environment, RK can work towards cultivating a more positive self perception and ultimately lead a more confident and fulfilling life. Then we give some of the recommendations to the patient. You can just see them, I'm not going to read them out. And finally, diagnostic formulation and diagnostic impression. Diagnostic formulation includes the significant features of the client's history. So here we write the same. Mr. RK presents with symptoms consistent with low self-esteem, characterized by persistent feelings of inadequacy, self-doubt, and a negative self-perception. These feelings appear to stem from growing up in a competitive environment with high familial expectations, particularly compared to his successful siblings. Recent life transitions, such as his sister's graduations, have exacerbated these feelings, leading to a significant decline in his self worth and overall mood. While Mr. RK may exhibit symptoms of depression and social anxiety, the core issue appears to revolve around his self esteem difficulties, which impact various aspects of his life, including work performance and social interactions. A comprehensive treatment plan for focusing on improving self esteem, challenging negative self beliefs, and developing effective coping strategies is recommended to address Mr. RK's presenting concerns. Psychotherapy, such as CBT, aimed at restructuring maladaptive thought patterns and enhancing self confidence, may be particularly beneficial. Additionally, supportive interventions and regular monitoring are essential to track progress and promote Mr. RK's overall well being. Then, diagnostic impression. Low self esteem, F3320, this is according to ICD. Mr. RK presents with persistent feelings of inadequacy, self doubt, and a negative self perception, which significantly impact his daily functioning and overall well being. These symptoms are exacerbated by familial pressure and recent life transitions, contributing to significant distress and impairment in various domains of his life, including work and social relationships. While Mr. RK may exhibit symptoms overlapping with depression and social anxiety, the primary concern appears to revolve around his low self esteem. Further assessment and evaluation are necessary to confirm the diagnosis and develop an appropriate treatment plan. So, this way, we complete the report. As we conclude, I hope you feel more confident in your ability to write effective internship case study report. If you found this video helpful, be sure to like, comment, and subscribe. And if you need any help or you need a copy of this, please write in the comment box or mail me. I will send you a copy. Thank you for your support. And until next time, keep refining your skills and embracing the journey of learning. Thank you.